he sit down. That's all what he said. And the whole European community there look at each other and said, oh, that's that's deep inside. Everybody applaud, everybody applaud. That's what America is about,
Yeah.
It's like the president of the American College of Surgeons, famous South Africa was the president. I forgot what the name was. He was my boss in Wayne State University. In the college, he go and insult the Americans. He said, because the shock trauma is like you fear something like that, but he has a British accent.
Okay.
And it was stupid what he said, but the British accent, all Americans applauded. If I say something with a Spanish accent, they throw me stones and everything else,
Yeah.
But because he has a British accent, because
you have to
South
bring
African, everybody say, oh, profound, deep, very good, very good.
Okay, I think we can start at 8:05. I guess we can let people join as they join. So I welcome you all to the Tele Trauma Grand Rounds. So today we have Dr. Carlos Menegozzo, who's the attending surgeon, director of Surgical Point of Care Ultrasound Group, the Division of General Surgery and Trauma at the University of Sao Paulo. And he's presenting a case titled Double Jeopardy. And I'm very curious to know why it's called that. Okay, so over to you, Dr. Menegozzo, to start your presentation.
Yeah, thank you very much. And I appreciate the privilege to present this. So I plan to do more interactive discussion here. So I have a lot of, I separated a lot of questions for you guys. And it would be awesome if you could also answer the questions in this platform. So I don't know if you all know this Socrative student. It's a platform where we can send responses to questions, and we can use this to see the answers of everyone and then start discussing. So if you use the QR code, you are going to go directly to the URL, and you can put PTS22 in the room name, so you can access the room. It's already with the first question there. And if you prefer, you can just type Socrative student in the Google, like in the Google console to make sure you find the right URL, and then just use PTS22 in the room name, so you can start with the polls, and I will share the results here in the screen. So the case was a 23-year-old male patient. He was victim of a gunshot injury during a robbery attempt. And the pre-hospital guys, they went there to the scene, and they told us these vital signs, that he had a Glasgow of 15 and he was hemodynamically stable. We didn't know exactly what were the vital signs, the numbers for those, but we know that he was stable as they told us. And the transport time from the scene to the hospital was 25 minutes. So the primary survey that we did in the hospital, so he had clear airways, he had diminished breath sounds on the left side. He was, his O2 set was 95% on bag mask. He had adequate perfusion, heart rate of 110, and SBP of 110 also. His Glasgow was 15, and he had a left forearm through and through wound, and also a left torso wound, and in the anterior axillary line, approximately in the 6th intercostal space. So the first question that I plan to do, oh, I'm sorry, and we had the gas for him for his primary survey. So his pH was 7.31, his base deficit was 3.8, and his lactate was 14 in this scenario. So the first question that I would like to ask you guys is, what would you be concerned of in this type of situation? You can everyone can answer in the chat, in the platform, the Socrative student platform. And also I'm going to open this now for discussion and for the panelists to join in and just tell us what you're thinking about this case.
Dr. Rodriguez, would you want to make your comments about the case?
No, it's interesting way of presenting, but I like it. I like it better than the other ones because they put a lot of information that is useless. I'm interested in seeing that there are theoretically two injuries, one in the arm and one in the chest. And the chest, I question if it's in the chest really or it's chest and abdomen, because it's 6 intercostal space. Could be the liver could go very close to go to the liver area to the abdomen. The base excess is interesting because that's what in America we are more concerned, more than lactate. Lactate we use it mostly when the patient is already in the ICU, but the base excess is what telling. In this case, it's 3.2. That's not too bad. He's a little bit of shocky, but no, it's not 5, 6 of base excess. So that's important. That's all at this point. And one of the things I learned in trauma is that the less I think, the better for the patient. You know, I have already conceptualized my pattern or how I do the things 1, 2, 3, 4, 5. I'll do the same thing in everybody, and always never fails. If I start thinking, you know, this, but people wrote like that, there's a paper about that, the patient is dead. So that's my personal opinion. And because I did that for 40 years, that I stopped thinking too much about things and trying to find, you know, another foot to the cat.
Yeah.
And Dr. Unchak, do you want to make your comments about the case?
Certainly. So I missed the base excess. Did you say 14 or 4? Or, not the base excess, the lactate level.
Yeah, the lactate is 14.
14. So that's rather high. And base excess, do you mean minus 3.8? Is that
Yeah, exactly.
minus 3.8?
Yeah, it's base deficit
minus
of
3.8.
3.8.
Right. Okay. And also the pH is 7.31. The pulse is elevated and no breath sounds on the left side. So that's my concern, that they say stable, but you know, if you're really stable, you know, if he had a normal lactate and a pH was a little higher, then okay, you can take him to CT, but I wouldn't do that here. And when you say double jeopardy, I think that's what you mean. Apparently he was standing like this and he got shot there in the forearm, and then so in and out here and then in, but no exit wound, and then no breath sounds on that side. And the double jeopardy is which cavity, like Dr. Rodriguez said. It's both the chest and the abdomen are in jeopardy. So that's my concern. And do you want to know what we would do, or is that the next question?
Yeah, it's going to be the next one.
Okay, all right. Well, that's my concern, that he's got a hemothorax, he's about to go into shock, and you know, I would not be too comfortable with the situation.
Perfect. So I'm really sorry I didn't put the normal values here. So for arterial lactate, 14 is the upper limit for us. It's between 4 and 14, like the normal levels here in our labs. So
I told you the only thing in common with Brazilians is soccer.
Yeah.
Okay, that in America that would be
that's
very high.
Yeah. Okay.
So I just wanted to show you guys the one of the answers here was impending shock, left hemothorax, that you just talked about. So that's perfect. And then we move to the second question, and this one is multiple question answer. So you can also proceed answering in the Socrative student if you like, but now the question is, how would you proceed in this situation? Would you ask for a chest ray? Would you put this patient in the CT scan? Would you perform an extended fast, or would you take him to the OR for surgical exploration? So feel free to join the discussion, and also if you guys want to answer this in the Socrative student, you can. So the first answer was extended fast. If you guys from the panel, if you want to comment on the answers, it would be great also. Oh, and just to make clear for people who are joining now, you guys can join us in the Socrative student platform. If you go in Google, just type Socrative student, and in room name you put PTS 22, and you can join the answers also in the Socrative student. So does anyone want to comment any of the options? What would you do, Dr. Rodriguez or Dr. Antrak? Yeah.
Yeah, I think the extended fast is the ideal thing, because we're allowed to see there is blood in the chest that we know there is more likely there is, and also it will show that there is fluid in the belly, if there is or not fluid in the belly. Now, the fast is very important because call it extended or no extended, because if the fast is positive and the patient is hypotensive, which is not this case, this patient in America go to the OR. But if the fast is positive, if the patient is normotensive, more likely that patient will go to CAT scan. That's the rules I have, and many people do. That's the way they do. They use the fast for that differentiation. In this case, so the answer is correct. I think extended fast. I don't think anybody is going to explore the patient. Nobody will take this patient on CT scan with no knowing what exactly is going on. And the other chest X-ray, you are in place where there is even in trauma centers in the United States, there is a plaque already under the patient in the table. They shoot it in 2 seconds and you have the X-ray, but the extended fast will occupy that position. You don't need to do chest X-ray.
Yeah, in Brazil, in some services, for at least in mine, you take a lot of time to get an X-ray in the trauma bay. So that's why we always have to decide which one to do, which one to call, when to do it. Dr. Antrak, do you want to comment?
Yeah, so I agree with Dr. Rodriguez. Chest X-ray is fine, but you can do the ultrasound much faster. You don't have to wait for the machine, unless you're in the center where it's right there. But still, the ultrasound gives information about the abdomen that you won't get with the chest X-ray. So I would certainly do that. And if there's evidence of a hemothorax on the left, I would put a chest tube before doing anything else. If the patient remains stable, I agree that it's okay to proceed with a CT, but that's how I would proceed.
Yeah, I would like to add something else, since you talk about chest tube for the students. The chest tube, we always put big mamas, we put 40 chest tubes. There's not many 40 these days, 36. Wow, 36. Chest tubes are there for drainage, not for ornament. That's why I tell the residents, no point to put it 22, 28. This is trauma. More likely hemodemothorax, you need to drain properly. So a number of 36, 40 chest tube. And remember, never below the 4 intercostal space. Otherwise, you will do a chiscava or an anticucho, or the liver or the spleen.
Yeah. That's interesting, because there's a lot of discussion nowadays with using also pigtails for hemothorax and trauma. So it's a nice thing to discuss in this situation.
Those are the guys who never learn how to put a chest tube. Yeah.
So that most of the people also answered for extended fast, and that's exactly what we did. And I know, I mean, I am biased in this. I must confess, this is my disclosure in this presentation, because I always struggle to bring the images for the meetings, because we always see CT scan images, but rarely we see the ultrasound images. And I love ultrasound, so that's why I try to document everything. So this is what we have. We have all these windows to see and to discuss. This is one of the main ideas of this presentation. So normally I just ask for someone to choose this, but in the interest of time, I'm just going to pass by. I just wanted to know if you guys want to see first the thorax or first the abdomen. So just make sure that I'm going in the right track here. So what would you say, the abdomen first or thorax first?
Thorax first.
Thorax first. So okay. So the injury was on the left side. There was no exit wound, so we're not sure what was the track of the firearm injury. So this is the left apex of the patient, and I don't know how which one of you guys are very familiar with these images. So I'll just run through them quickly. So these are the ribs here. This is the pleural line, this very bright line here and here. And we can see that there is pleural displacement here. So the pleural line is moving, and that guarantees for us that in this place where the probe is, there is no pneumothorax in the apex of the lung. So that was one of the first images. And then I put the ultrasound probe in the left anterior side, and then we can see the opposite of the thoracic scan, which is here are the ribs as well. Now here is the pleural line moving, and on this side the pleural line is not moving anymore. So this is a characteristic sign of pneumothorax. It's called the lung point. This is the lung point, this image, where you have the transition between the moving pleura and the still pleura. So this was the first interesting thing in this case, because normally we put a probe in the apex of the lungs and tell everyone if there's lung movement or not. And in this case, and we are using this in Brazil, also in São Paulo in our service, we scan all the anterior aspect of both thorax to make sure we're not losing any signs of pneumothorax. So we found the pneumothorax there, and the left basal image is this one. So we can see here is the spleen. The diaphragm here is this pleural curved line. This hyperechoic curved line. You can see some parts of the stomach here in these dots, this bright dots. And here's the lung, and also you can see there's some fluid around the lung here. So this is a hemothorax. So confirming that the projectile entered the chest cavity and caused a pneumothorax and also a hemothorax in this patient. Also, the left now in the abdomen, we did not see any fluid in the abdomen here in the splenorenal view. Also in the subdiaphragmatic left subdiaphragmatic, there was no signs of fluid as well. And we were also concerned about having cardiac injury because of the injury entry wound, and you can see that there is no fluid around the heart. So this is the subxiphoid view, the right ventricle, the left ventricle, the left atrium, and the right atrium here, and you can see the pericardium, the posterior pericardium here, this bright line, and also a bit of the anterior pericardium over here. Also, Dr. Antract, he raised his hand. Please go.
Yes, so you showed yes. So about the image of the spleen and the kidney, and what I look for is that, yeah, that's it right there. So I think you can see the vertebral column to the right of the image, and it looks like it might be extending beyond the diaphragm. That's what I look for. I'm just wondering if you had seen that there. That you can see when you look at the spleen and the diaphragm.
Yeah,
did you see in this case that it looks like the spine might be extending above the diaphragm, and the only way you could see that is if there's fluid in the pleural space on that side. So that's that's usually what I look for on either side.
Yeah, and you're correct. In the left side, you
and
have,
I guess you see.
I'm sorry.
Go ahead.
And you're right. On the left side was there was fluid in the pleura. Yeah, that's correct.
And you can see the vertebral column above the diaphragm is what I would look for.
Exactly here, right here, right?
Oh yeah, right. It's kind of at the edge of that view, but it looks like that's what's there.
Yeah, exactly. It's perfect. And in the subxiphoid, so we always look for fluid here, and there's no fluid. But also one of the things that caught our attention, if you guys look closely here in this image, you will see that there's a bright image that is moving with the beating of the heart, and it's on the pericardial topography. So that was a big concern for us, because it resembles a pleural line here with a posterior echoic image. And that in ultrasound, it's very typical of pneumopericardium. So we were concerned that the projectile could have hit the heart also. So that was a big concern. I'm going to show you the right base of the lung because you have interesting findings also here. So you can see that there's a little bit fluid over here in the apex of the image, in the pleural space, very little fluid that ultrasound can view. But what was really interesting in this image was this bright image in the liver, this hyperechoic linear strain in the most upper limits of the liver. And in our view, it seems that the projectile was passing from the left side through the right side. So this is one image that may resemble a contusion in solid lesions, in solid organs. So we thought now that we are actually dealing with a transmediastinal injury instead of only left or left thorax or abdomen injury. So that was a big concern for us. And the rest of the images were negative. So I'm going to, in the interest of time, going to go through the images just to make sure we're going to be on time. So now that we have this patient, he is we're giving the fluids and giving him the resuscitation in the trauma bay. I wanted to ask you guys if you would do anything additionally, any additional interventions before CT scan, or even if you wouldn't go to the CT scan. And the patient is not getting worse. He's stable. He's a little bit tachycardic, but he's not a hypotensive, and things are going well in terms of resuscitation. So I wanted to ask you, the panelists, what would you do, and using this list, or if you want to do anything that's outside this list, you may do it as well, no problem.
Can I make a comment? Yeah.
Sure.
First, I want to congratulate you, doctor, because your descriptions of the chest fast part of the part of the city, the chest part, is very comprehensive. I never heard that. I never saw that. To be honest with you, despite we wrote the first paper in the United States in 1992, before Dr. Rosicki, 2 years before, on sonography and trauma. But we concentrate only in the abdomen. Yes, in the last 15 years or 20 years, they start thinking about extending to the chest. So I have to confess, despite I was the pioneer of FAST, we called it sonography in those days, and trauma, I never went into the chest. So I am perplexed, amazing, all the details that you describe in the chest. Now, saying that, if this patient will be unstable, this echo fast will help me a lot to make decisions what I'm going to do, and hurry, operate or not. But this patient seems to be stable. So if I am reading, I'm not practicing this time trauma, but for 40 years of trauma, for me, this patient, the echo fast is very helpful. It's a sort of pathway what I'm going to do. In this case, with the patient stable, I will do the F. Get this patient to CT before deteriorated and give me a more complete evaluation. And all the other questions, maybe this is, maybe it's not, a Colombian soap opera. No. I think my CT with contrast, because if this is a transmediastinal wound, we used to do CT, angiography, CT with angiography, esophagoscopy, esophagogram, and and the rest. So there's three things that we need to rule out injury and transmediastinal, because that's why you're calling this a transmediastinal injury, correct? That's what give me a lot of information. So conclusion, for me, the echo fast is good, telling me more suspicious and help me to doing a CT who clarify the whole thing.
Interesting. Dr. Aurelio, thank you very much for your comments. I feel very honored and privileged to be in this meeting with you guys and learning a lot. And I must confess that after we saw that the injury was transmediastinal and passing very close to the liver, one of the residents found the bullet in the subcutaneous area in the right side. So I thought, oh man, we were trying to differentiate the path of the project for a while now, and now we have evidence also that it went to the right side. So That was interesting. So thank you very much for your comments for the CT scan. Dr. Utrecht, do you want to make additional comments?
Certainly, I think that that's reasonable in this case because the patient has been breathing well, he's oxygenating well. I would put a chest tube in first, but because you can see how much blood comes out, whether there's ongoing bleeding, and also looking at your ultrasound views on the right side, it looks like there was the same visualization of the vertebral column above the diaphragm on the right side. So, that's consistent with a transmediastinal bullet that may have gone into the right pleura without causing a pneumothorax and then immediately into the liver. But it looked like that's what your images showed. So I would first do the chest tube, then go to CT, but I think it's not wrong to go to CT first, given the condition of the patient, and you would know best with the patient right in front of you what he needed.
A commentary, if I can, for the residents and students. Bullets don't follow trajectories. They used to teach us put clips in one entrance, a clip in the other side, and the assumption was that the bullet went that direction. Bullets do not follow trajectories. Bullet can ricochet, can touch the bone and go in different directions. So you can be totally fooled with those famous clips of coins that they used to put when I was in training and my beginning of my career.
Yeah.
Thank you, Dr. Rodriguez. Yes, Dr. Andre.
Unless there are more people that comment, but I forgot to say at CT scan, I would also give him some oral contrast to drink for the reasons that Dr. Rodriguez mentioned. That kind of trajectory, it could have easily have injured the esophagus.
Right.
Where that path of the bullet, not trajectory, but the path where however the bullet went.
Yeah. Would any of you guys repeat the FAST exam for any reason? Because we have a answer like this in the Socrative platform. No.
You are in a place where you don't have CAT scan available, that you have to call the general to give the order to open the CT scan room. Yes, but if you have a CT, I mean, obviously, people repeat CTs. It's very useful to repeat CT, particularly even if you do a CT, you can repeat CT. The fast would take 5 minutes, 3 minutes, and CT is flat now, and the place was not before. But no, that will not replace my CT with my first step if I have a CT.
Yeah, that's perfect. So
one second, Dr. Menegozzo.
Oh, sure.
I'm just going to ask Dr. Hodgman as well. I know you came in late, but Dr. Hodgman, do you have any comments?
I didn't hear the presentation, so no, sorry.
That's fair. Okay, you can continue, Dr. Menegozzo.
Okay, no problem. Thank you. So we did what Dr. Utrecht also thought about. So we did a tube thoracostomy at the left side. We got 350 cc's of blood, and you can see this part of the presentation where the bullet wound was and where the chest tube was put in. So this was the entrance wound, and he had no exit wound. And then what we did, so we have the images of the CT scan. I'm going to show you now. This we didn't use oral contrast. We just used IV contrast. And this is the thoracic view of the CT scan. You can see there's a little bit of fluid in the right side, a little bit fluid in the left side also, and you can see that the chest tube is right here. And we were looking for some injuries also in the belly, and any signs of injury maybe in the heart. So you can see that there is no free fluid and no pneumoperitoneum in this image also. But what I wanted to show you guys is that you can see a little bit of pneumopericardium here, over here in the anterior aspect, where we could see it in the ultrasound as well. You can see a little bit of the trajectory of the bullet in this image, and you can see that it's passing very closely to the aorta and to the vena cava with a lot of mediastinum gas. You can see some subcutaneous free gas as well, and you can see also the contusion and in the liver and the upper aspect of the liver here as well. So the findings were very consistent with the findings from ultrasound. And I wanted to show you also the lung view, the lung window of the the thorax, and you can see just in the start of the CT scan, you can see a little bit of pneumothorax here. You have already the drain put in the left side, a little bit of fluid here, and you can see a very nice image of the trajectory in this view of the CT scan. So you can see that it's going through and through the left into the right side of the patient. And I wanted to bring you also a sagittal view, because it's interesting to see how the bullet, so the bullet is here, is in the subcutaneous area of the right side, very close to the liver. You can see as well the signs of contusion, which we could see using ultrasound. This is the chest tube over here, and you can also see the bullet trajectory here. And we were really concerned of having mediastinal injuries in this patient, as you could see in the CT images. We didn't see any overt signs of contrast extravasation or any direct signs of injury, but we were still concerned of this. So how would you proceed now? Would you take this patient to maybe just observe the patient? Would you surgically explore? Would you call for an endoscopy, or would you call for an arteriography or venography to make sure you are ruling out the injuries? What would you guys would do?
Dr. Antrek, would you like to make a comment?
Well, yes. So the issue is there, there's an injury to the pericardium, there's pneumopericardium, but there was no blood in the pericardial sac. With a bullet that crossed the mediastinum. Is really lucky that it didn't puncture the aorta, but the other people that week that were hit the aorta, you didn't see. They didn't get to you. But so in this case, I would do more studies, but I don't know if you can do an endoscopy. That might be quicker than doing a gastrographin swallow or repeating the CT with contrast. Either of those would be okay. And then there are no signs of the CT scan of aortic injury, but the issue is, do you need to do anything further to evaluate the pericardium? So the choices are to do a subxiphoid pericardial window, and then also it looks like you did endoscopy, which is fine, to look at the esophagus, and you have contrast in the aorta, and that part looks fine. Yeah, the aorta looks fine. So the issue is the esophagus and the pericardium. So I would whether it's endoscopy, like it looks like you did, or contrast study is fine. And then I might ask the heart surgeons what they think about the image of the images around the heart, to see if they agree that you need to do a subxiphoid window or some other evaluation.
Perfect. Thank you very much, Dr. Antrek.
Can I make a comment?
Dr.
Yeah.
Rodriguez.
3 comments. And number 1 about the simple thing. This again for the residents or medical students. Chest tube, never below the 4 intercostal space. Big mama chest tubes. And the most important thing, how do you secure the chest tube? In America, they always give it 2-0 silk. Well, too bad. We always use number 1 nylon, big mama nylon, because the nurses would usually trip on the chest tubes in the middle of the night and pull the tube out. In order to pull the tube out with number 1 nylon, you have to take a piece of chest with that. So 2-0 silk, very easy. Cut. This is America. This is the world. This is reality, Okay. Number 2, in regard to the injury of the aorta, there are 2 signs in the CAT scan who disclose aortic injury. Number 1, abnormal contour of the aorta, and number 2, periaortic hematoma. This patient, I don't think have neither one of those. Now, it doesn't rule out 100%, but doesn't. In regard to esophagus, we wrote a paper. If you do just endoscopy, it's 50% chances you find the injury. Sometimes it's hard to find it. And you do an endoscopy and esophagogram, both is a 90% chance to find the injury in the esophagus. Okay. So in regard, I saw that same thing like the doctor who is in Iraq is thinking. I think, how about if I do a pericardial window? For me, it's easy to do a pericardial window. Not everybody has done pericardial windows. And I think that when you do a pericardial window, you have to be very careful, don't contaminate with blood from the outside into the pericardium, because otherwise it falls positive. You do very carefully sub-siphon the pericardial window. I like to take the siphon to more exposure and pick up 2 axon clamps, and then very carefully you open the pericardium with suction immediately there. What happened? If it's pure blood, that means it's an injury. It's a cardiac injury and to prove otherwise. You can say, but yes, maybe it's only the pericardium. Okay. I know these days trauma surgeons want to be minimalistics. With the minimal thing they do, the better. Okay. But in the real world, we do the pericardial window. If it's positive, blood coming out, you have to do mid-sternotomy. If it's negative, well, it's negative. Okay. If it's a pink cam, the book doesn't say what you do if it's pink. My book said it. You repeat it. You wash it. If it clear up, it's just you contaminate from outside inside. This for the how you do it, how you evaluate the pericardial window. So in this case, I think what we're saying seems to be correctly, and this is the things I wanted to comment.
Perfect. That's awesome. Perfect. Thank you very much. So this is what we did. We did an endoscopy in the trauma bay. We called the endoscopy guys, and they showed this image, which is at the posterior aspect of the esophagus. So they thought that this could be an indirect sign of an esophageal injury, although they stated that the mucosa was not teared, but they thought that could be a posterior injury of the muscular layer or a hematoma, and they were concerned about the trajectory of the bullet also. So I just wanted to show you one little aspect of the CT scan that we discussed with the radiology guys, and they thought that there was a little bit of like a blurry of the contour of the aorta in this side of the injury. So this is the place that they thought it was a little bit blurred. So they were a little bit concerned of having a partial injury or contained injury, and that's why we also asked for the opinion of the vascular surgeons that work with us in the ER, and we also did the endoscopy that suggested that there may be a posterior hematoma in the esophagus. So we took this patient to the OR for interventional evaluation.
Sorry, before you continue, can I make a comment about all this?
Of course.
I noticed that scene in the aorta when you were going through, and so in any heart injury, I always preferred median sternotomy, and so if you do a subsiphal window, you essentially commit yourself to a median sternotomy, except in a case like this. A case like this, call me crazy, I'm probably going to say something that's going to be very controversial. I would take this patient to the OR, and I would have this patient intubated with a double lumen tube. And I will do a left posterolateral thoracotomy, kind of a very low thoracotomy. I will look at the sagittal views also to get an idea where the diaphragm is, because I had the feeling that the diaphragm will have to be taken down because the trajectory of the bullet, there are 3 things that I am worried about. One is a posterior injury to the heart, which would be the left atrium. Can you repair that through a median sternotomy? Yes, but you cannot repair an aortic injury. So that's the reason I would do a posterolateral thoracotomy that can address both. And in the worst case scenario that you have an esophageal injury, that will also be the incision of choice. Because he has the big pulmonary contusion on the left, that would be another reason to isolate the lung to prevent bleeding from the left side into the right side. But I will take this patient to the OR because the things that I am worried is about an injury to the left atrium and an injury to the aorta. I don't find anything, I will do the endoscopy in the OR and go that way. That would be my approach. Probably wrong, but I just wanted to say before you guys move forward. Thank you.
Oh, there's no right or wrong here, no, Dr. Hoffman.
Yeah, no,
So-
I think, Dr. Horacio, you are from Argentina, right, Horacio? Horacio, doctor. Hello?
Yes.
Yes, sorry, my microphone. Yes, I am from Argentina, but I am in
Yeah.
Boston now.
Ok. Favaloro, qué sé yo. Bueno, anyway,
I trained in I did my general surgery residency in the hospital where Favaloro was.
oh, here you are, you know, you cannot defeat an Argentina, as you had to listen to Brazil, right? Okay, anyway, but I think he's right. No, we didn't say we are going to do a mid-sternotomy. We said that when I was explaining, when you do precardiac window, that's to rule out cardiac injury, and that's what you do, but fluid, mid-sternotomy, no blood, it's negative, and the pink, I told you, you irrigate. Now, I think he's right in the sense that the left anterolateral, if you really think this patient has an injury in the aorta, okay, you have two options. You can do left anterolateral thoracotomy. Remember, this patient is stable, right?
Yeah.
Thoracotomy and address the aorta. Now, normally the rupture aortas and blunt trauma, by example, they are not that low. They are high, you know, they're high. So you have to go in the third intercostal space. Otherwise, you go too low, it's very difficult to do it. But in this case, it's different. As Horacio said, you know, the trajectory seems like it's very low near the diaphragm, etc. So he's going for a low incision to try to address the aorta. I question, you know, these days with the use, I never did that because that is done usually by the angiographies, whatever it's called, those radiologists who put the stents, they put stents, you know, for aortas. Usually in blunt trauma, I don't know if they put a stent for penetrating trauma, probably not, but that's an easy way to solve the problem if you think that there's an injury there. Now, the esophageal injury, doing the left anterolateral thoracotomy, as Horacio said, you kill two birds at the same time. You rule out or rule in, or you treat the aorta. If you have the esophageal injury, then you deal with the esophageal injury. Now, it's going to be difficult. Let's pretend, Horacio, that you have an injury in the aorta. You know, if you have penetrated trauma, I guess maybe you can just do a repair. You know, primary repair, like they do the Adventists in the United States. They usually they don't use stent. They use, excuse me, they don't use graft. They use primary repair and patch it with a piece of pleura or something like that. Because putting a stent there, or excuse me, putting a patch there, you know, you have esophageal injury, that's you can blow everything out. So we are in the same scene, we're saying the same thing in different scenarios, but I think it's an interesting situation. It's getting more complicated now.
Yeah, exactly. So we asked for the vascular surgeons to help here, and they thought that they were concerned about the aortic injury and also maybe a vena cava injury because of the trajectory. So they decided to do our aortogram here. And you can see that there's no contrast extravasation in the aorta, and also there was no contrast extravasation in the venous vessels here in the cava, and also going to the hepatics. So that was so we basically did not get any more concerns about aortic injuries or vena cava injuries in this particular situation now. Of course, you can have burn injuries and all sort of things in the vascular also setting, but that was the scenario that we were in this part now. So would any of you guys start this patient and just observe? If you have any other, we did CT scan, we did endoscopy, and we did vascular evaluation. Would any of you just observe this patient, or would you think that this patient needs to get to the OR and you have to explore any of the possible injuries? What would you say?
Yeah, I would like to make a comment very quickly.
Sure.
If in the old days, you know, when the CAT scan was not the golden thing for rule out rupture aorta, we used to do angiograms. And the
Yeah.
angiogram, it was positive or was negative, and sometimes was doubtful. I actually was involved in 200 rupture aortas and blunt trauma. I didn't operate at 200, but I was involved. There were only 2 cardiac surgeons. I was the cardiac trauma surgeon. And I'm telling you, it's horrible. It's a simple procedure. When you do a rupture aorta, you dissect it, and then you have a big mama hematoma, and under that hematoma, you cut wrong, the blood go all the way to the roof, and patient is dead. You can put your whole body inside to control, and you cannot control. You have to get proximal control and distal control, and that's tricky when you have hematoma. How do you get between the subclavia, and the carotid there, and the top, and the bottom, and all this stuff? So it's not an easy procedure. When they come the stents, I bless God. They said, I don't have to do that, because every time I had to repair an aorta, despite I was involved probably 100 of those, I lost some, it's not an easy thing,
Yeah.
The cardiac surgeons in my generation who were becoming rich doing the coronary artery disease surgery, they were not interested in the aorta. Hopkins sent me all these patients to me, the University of Maryland. They didn't want to do an aorta. They have 3 bypasses next day. Why they want to be involved at 3 o'clock in the morning trying to open, disassemble a bomb? That's what it is. Like you unassemble a bomb, it's going to blow up. Anyway, the point is this, doing the angiogram, I like that, because the angiogram normally these days don't do it. They do it precisely in that situation. When the CAT scan is not very clear, then you go back to the angiogram, and then you say, really, I don't see anything. Okay,
Yeah.
The lawyer cannot sue you because you did the angiogram. Now the question is, now what do you do? There's something here is not clear. Why he has air pneumopericardium? Did he has a communication between the esophagus and the pericardium, or the esophagus? We saw something in the esophagus. Okay.
Yeah.
Now the question is, what are we going to do with that?
Exactly.
We're going to sit and say, okay, let's don't feed him for a week, and then repeat again the esophagoscopy or do esophagogram, and if everything is clear, then they start feeding him with anticuchos and Peruvian food, ceviche and everything else. So that's a good question to answer now.
Yeah, exactly. So let's see what everyone is telling. 3/4 of the people would observe only, and 1/4, one person responded that this patient needs an operation. So yeah, that's exactly what we are dealing here with now. Dr. Untrak, do you want to make any comments, or Dr. Hochman?
Yes, so I would say that now the only well, there are 2 issues. First of all, the CT image that you showed that irregularity on adjacent to the serosa of the aorta, that looked like it was intra-abdominal, and it was below the path of the bullet. The bullet at that level was in the liver, but in any event, I think Dr. Hochman's approach actually would have worked well, regardless of where, if there was an injury. If it was above the diaphragm, then the thoracotomy would have worked. If it extended below the diaphragm, it could have been converted to a thoracoabdominal incision. Then you can get the good control, much easier control, as Dr. Rodriguez was saying, and then you can address everything. If only the esophagus is injured and it's not a transmural injury, if the mucosa is intact, that at that level would be much more easily dealt with through a laparotomy. You can just mobilize the lower esophagus and wrap the fundus around if you needed to, but it looks like you don't need to in this case. So the only, and I said that I would observe the patient, but my only concern is about the pneumopericardium. So the patient stable, I would call the heart surgeon, see what they said, and perhaps he might need, to be safe, subxiphoid pericardial window. And if there was any doubt, a median sternotomy isn't a very morbid operation, especially for a young person. You open, make sure everything's okay, and close it. And I wouldn't hesitate to do that if there was any doubt.
Perfect. Excellent.
So
Dr. Hochman, yeah.
nowadays the CT scan has become the gold standard to diagnose vascular injury. Yeah, I remember when we used to do angiogram because the CT scan was not enough. So you have, again, I probably need to see the CT scan again, but the scene that we were, you don't see extravasation. That doesn't mean that there is not an aortic injury. The aortic injury, like appears to be in the esophagus, might involve the adventitia and the media, and the intima still be intact. So the angiogram is not going to show you that. And so I will still be concerned, particularly because of the trajectory. There is air in the pericardium. So the trajectory, there are not too many things that can that this bullet can miss with that trajectory. It's all together there. So it will be very unusual to miss the heart, the esophagus, and the aorta and pass through. So I still think I will approach this with surgery without any further testing, because I am concerned about those 3 injuries. It will be the esophagus alone. I would probably watch, but the other 2 will make me very worried, and I would probably go ahead with the surgery, as we were saying. The problem with the median sternotomy that you cannot access the aorta there. So you cannot, the moment that you commit to a median sternotomy, you're stuck. And if when you start operating, you get into bleeding, it's very difficult to control from there. I remember an old thoracic surgeon one taught me a trick to go through the posterior pericardium. I really pray that I never have to do anything like that, because it appears to be extremely difficult. And I never did it. So I will do it out of desperation if I have no option, but I will try to avoid boxing myself into a situation like that. Thank you.
Yeah, I would like to say something regarding to we mentioned middle sternotomy just as we were explaining when we do pericardial window and we ended doing middle sternotomy, that kind of stuff. But we agree with that. The middle sternotomy is nobody operate a aorta through middle sternotomy, even Porteños cannot do that. Okay.
No,
So,
the surgeon who told me that was an Indian guy. Okay, and he was a very good one.
Yeah.
He said, oh, you can do it like this, whatever. I never had to do it. I don't never want to do
it's
it.
impossible, almost impossible. But anyway, but the other thing here is the fact that the esophagus, that it is something seems to be holding there. In other words, we can be very aggressive because the patient is stable, and to do all these surgical procedures could be considered aggressive, but then the other side could be maybe definite, as Horacio said, to send the problem, But these days, I repeat, and by the way, to call cardiac surgeons, with all respect, I did 2 years of cardiac surgery in Wayne State, not to be a cardiac surgeon, to be a better trauma surgeon. I did 2 years of thoracic cardiac surgery. They don't have much experience in repair aorta. Remember, we were in the Intergalactic Center of Trauma of the Universe in Chief Trauma in Baltimore, and we saw only 10 a year, and we were a referral center. So most centers of hospitals in the United States will see 1 a year, or 2 a year, or 3 or 4, but they don't see enough. They have 10 cardiac surgeons, maybe that's once every 2 years. So to call him an expert, there are many, most of the papers written about rupture aorta are done by trauma surgeons, the case by Jim Moore, Jim Moore is not a cardiac surgeon. They did that. They don't call the cardiac surgeon. Cardiac surgeons don't want to be involved in the first place in this. They don't want to be involved in the rupture aorta. They have more money in other things that to a rupture aorta.
Amen to that.
So I have this other question in the Socrates. I'm just going to pass through this really quickly in the interest of time, and I really apologize to everyone. I think I'm going to pass probably 5 or 10 minutes, if that's okay with you guys, past from 11. So the question was what to do. So would you operate in the abdomen only, the thorax only, the abdomen then thorax, or thorax then abdomen? So I think that we started to discuss the possible injuries here. We did the endoscopy. We have concerns for esophageal injury. We kind of were a little bit more relaxed after the CT scan and the angiogram and the venogram showing no vascular injuries. So now, if Dr. Hochman would be controversial about the posterior thoracotomy, now I have no idea what to call me, because as Dr. Aurelio said, the trauma surgeons are really more to the invasive surgery and more less invasive surgery now. So we opted to perform laparoscopy and then a thoracoscopy in this patient. So this was the position. We normally put the patients for laparoscopy with both arms along the side of the body, but in this situation where we would need to explore the thoracic cavity, we put the arms open and also the legs open, so we can work between the legs for the laparoscopy. And I brought the videos for you guys to see. I'm going to really fast forward some parts in the interest of time, but you can see that there's almost no fluid in the abdominal cavity. You can see there are some spots here alongside the liver, a little bit of fluid in the right goiter, and now you will be able to see some parts of the contusion of the bullet here in the diaphragmatic aspect of the right side. And in the left side, we were looking for holes also in the abdominal cavity. There were none. So here's where the bullet was, and you can see that the peritoneum is not violated. So what we did, we wanted to explore the mediastinum through the abdominal cavity. So we started to open this just like a Nissen procedure, actually. And I'm just going to fast forward this. And again, we were more relaxed to do this because of the previous studies. We were not really concerned about having a vascular injury that was going to be detamponade, for example. So we just explored the mediastinum here, looking for the injury in the esophagus. So here's the right diaphragmatic pillar, here's the left diaphragmatic pillar, and we're going to go deeper in the mediastinum. So you'll be able to see there's a little bit of hematoma here where the bullet passed by. And it's very close to the esophagus, as we saw in the CT scan. So you can see that there's a little bit of hematoma here. And we looking at the posterior aspect of the esophagus, we could not find any tears in the muscular layer as well. You can see that the esophagus is over here, the posterior aspect is here. You can see some hematomas in the more in the outside aspect of the esophagus, but no injuries in the muscular layer or even mucosal tears. And in fact, we repeated endoscopy in the operating room, and that lesion, that bulge, was not found anymore. So we thought that this would be probably a hematoma, posterior hematoma that was compressing the esophagus anteriorly. So that's what we did. And then as I told you guys, we performed the thoracoscopy and we repeated the fast exam in the operating room. There was no fluid in the pericardium, so we were really relaxed in terms of having a cardiac injury. Also because there was no, the output of the thoracic drain was not important anymore. So we were not concerned about the blood leaving the pericardial sac to the pleural space and giving a false negative of a fast exam, because this is one of the most important situations of false negatives of the subxiphoid window, is when you have hemothorax and you get confused about where the blood is going. So when we did the thoracoscopy, we saw that there was a hole actually in the pericardial sac. You can see here, but no blood pouring from this hole. So what probably we thought that happened is maybe the bullet was really close to the heart, and it caused like an abrasion of the pericardial sac. It was open, but you didn't have any cardiac injury to make the blood coming out from the pericardial sac. So it was mainly a thoracic injury, and we just we did another we took the first drain out for the thoracoscopy, and we put it in a lower space in the left thoracic cavity. So that's what the results of the surgery were. And also, of course, we took the bullet off, and you have to, for the young surgeons, you have to do the sound the bullet going to the metal thing, because you have to do this to make sure you're taking it out, and patient's going to live after taking the bullet out, just as we see in the TV series. So post-operatively, this patient was extubated after surgery. He was on oral diet on PO on the first post-operative day, and the chest drain was removed, and the patient was discharged on the third post-operative day. So the last question that I have for you guys is, what would you say this patient was in this story? Was the patient the robber, or was the patient the victim of the robbery? And that's the last question that I'm going to put here in the Socrates students for you guys. And I'm going then to make sure to make some conclusions and list some teaching points for us in this case. Any final comments from you guys, Dr. Hochman, Dr. Untrach? Yeah, Dr. Untrach, you raise your hand.
Yeah, so it's a very good shot. So I would say it was probably the store owner. That's the robber that got shot. The store owner was well trained, very, very good shot. Probably scared this guy. I'll never do it again. And my question, I have two questions. First of all, during the thoracoscopy, you didn't show it, but I assume you looked at the aorta down, the descending aorta down to the hiatus. So I assume you did, and it was normal. You didn't see any hematoma there. And then also the vascular surgeons, I mean, we almost never do an arteriogram or a venogram anymore, but were they prepared to put a stent in if they saw an injury?
Yeah, they were. So
okay, so that's why they did that. So there you go. Yeah.
Exactly. Yeah, and we looked for the aorta in the thoracoscope. Yeah, we didn't perform any dissections of the mediastinum pleura, but there was no hematoma in the trajectory of the aorta.
Yeah. Yeah, and also I think that, having them there, if they're talking to them and they're so confident that, I think, that's reasonable not to do a big operation, and I think that's actually a good use of resources. So it didn't prolong the hospitalization, and you got a good look, and as well as you could do under any circumstances. So I think that was well done. That was a good choice of procedures that you did, but very nice case. Thank you.
Oh, thank you very much. Dr. Rodriguez, Dr. Hochman, do you want to make some comments here in this part?
Yes, in the first place, I would like to congratulate your group, because this is a fascinating case, a good case, a good management, and a success story. I want to say that the person, the choice to do the laparoscopy or thoracoscopy were good. I have, despite I wrote one of the first papers on laparoscopy when in the old days where they used to use no gas. They used to, like a circus tent, lift it up. That was crazy. I never have done laparoscopy after that. And I always make fun of laparoscopies. They are Chinese surgeons, because it looked like they were the sticks. But in this case, the person who did this is not just a laparoscopy. Anybody who does a hernia, gallbladder, this guy who did this dissection has to be good. This is a tricky dissection. This is not a simple, every laparoscopist can do what you see here. In cadaver, yes, but not in human. Now, you do this, you have to be prepared.
Yeah.
Because if you see the hole, you're not going to have time to open the chest or open the belly right away. So the guy who does that has to know, or have a real trauma surgeon there who know what to do, or the ones you open the belly chest, very quickly. So this is a risky business, but was successful, and actually was good to make all. As a matter of fact, there's a paper from a doctor from Medellin who does pericardial windows to thoracoscopies. Open the pericardium to the pericardium to thoracoscopy and drainage, and see if there is blood or no blood. So I think excellent case. I just want to make a final comment. In America and the United States, they don't use the word observation. You know that. We don't observe. We do no operative management, which is different. Observation is you just put your hands like that and observe. But no operative management imply other things. I know the translation, observación, Sounds
Yeah.
like in Portuguese, probably also Brazil, something like that, sounds like that. But here is no observation. We don't observe. We do no operative management. In case
Yeah,
you, okay.
you're right. You're right. That was a mistranslation from my part. And thank you for the comments also. I forgot to tell you all, of course, we had the laparotomy table prepared. We wouldn't have any time to do it if there was an injury. So we have the laparotomy table prepared. So if there was an injury that we had to open to see all the injuries, we would do it in no time. So my idea was actually to try to dissect from the belly and also from the thorax if I saw anything there, just to make sure that if possible we could offer the benefits of minimally invasive surgery for this patient. So that was actually what I thought about in this case. So about the last question, everyone answered that there's the robbery, and of course this robbery. If I was shot like this, I would probably have my aorta ruptured. So here in Brazil, we have the saying that when you have like an injury like this, and the patient has no lethal injuries or no injuries that need repair, this patient probably is the bad guy, because you have the good guys have no such luck here in Brazil. So that was one of the situations. So I just wanted to thank you all for having me in this meeting, and for the comments. I really learned a lot. I just wanted to point out 4 learning points that I wanted to share with you. And also, of course, if Dr. Aurelio or Dr. Utrecht want to comment afterwards, also it would be really appreciated. So the first learning point that I wanted to share is that I really try to every time to move beyond EFAST every time possible, and I really want to teach the residents to do more with the ultrasound. So I want all the time I want to explore all the potential answers that ultrasound can offer us in any situation. It may be in trauma, it may be in acute care surgery. I mean, I really believe that the surgeons need to have a good technique to use ultrasound more and more in the upcoming years. Also, I just wanted to remind you that this was a stable patient, but if patients are unstable, just as Dr. Aurelio told us, ultrasound can also help you decide which cavity you would explore first. So there's a nice paper from LA published in 2018 about this, and that's where I took the double jeopardy title from. So from this study, and they showed that using EFAST can help you find the problem and explore the cavity in less time than if you don't use it. The third learning point is that the CT is the gold standard for stable patients with trauma, especially with thoracoabdominal penetrating injuries. I don't want to only advocate for ultrasound. This is my big bias, but I'm really I have the very clear idea that the CT scan is the best the best option for these patients. And lastly, I want to remind everyone that minimally invasive surgery is a good choice in these kind of situations in stable patients with thoracoabdominal penetrating wounds. I brought you a paper that we published from our institution, and you can see here it's published in Surgical Endoscopy in 2019. It's a case series of 31 patients with a thoracoabdominal penetrating wound, and that were managed using laparoscopy. So it's a very interesting idea, especially when we are concerned about diaphragmatic injuries that are not very easily found in other situations. So once again, I thank you very much for your kind comments and also your time here, and we learned a lot here. So I just want to ask for Dr. Aurelio and Dr. Utrecht for the last comments, and maybe anyone wants to comment also.
Yeah, I want to tell you I'm learning about the thoracic part of the FAST, and I wish I learned a long time ago that I didn't. But it's amazing. These days in the United States, actually, the people, all the surgical residents by routine, they have to do FAST. Everybody who comes, just practice, because the FAST or echo FAST is the stethoscope of the trauma surgeon. It's not a special procedure, it's a routine procedure, okay? And the guys who know how to do echofast better than trauma surgeons and residents are the emergency room physicians in the United States, because they diagnose many other things other than the abdomen, the fluid in the abdomen and fluid in the chest. And finally, I think this case, it was very good. And now I know why the person who was doing this dissection with the laparoscope, it was good. It was you probably, after 31 cases. I mean, this was not just a regular person who does laparoscopy. This has to be somebody who has done that before. Thank you.
Thank you very much.
Dr. Unchak, do you have any final comments?
Yeah, certainly. Yes. Excellent presentation. And I really agree with you about ultrasonography. So many of my colleagues from my generation, they're Luddites. They're, it's something new. It's anytime something new comes along, it's always the older surgeons are resistant because we're set in our ways. And I think the younger generation, which you're a part of, are going to be the experts at this. But especially if you're in an area where you can't get to the CT scan quickly enough, or the patient's unstable, if you want to save their lives, unstable patient, you have to be comfortable doing ultrasonography, and you can do it. You can even practice on the other residents. It's not like having to wait for somebody that needs an operation to get to do the operation. Just practice, get good at it, and every time you examine a patient, just you put your stethoscope down, then look with the probe, and it was just superb use of the ultrasound. So you're preaching to the choir here, but I certainly agree fully with your approach.
Thank you very much.
Thank you so much, Dr. Unchak. Thank you so much, Dr. Menegozzo, for the excellent case. I think everybody learned a lot, but I especially learned a lot from the ultrasound part of it. And I like how you explained, the images, and you pointed out everything. I think it was an excellent teaching experience.
Thank you.
So thank you so much for presenting the case, and thank you to the panelists for your excellent comments. So yes, so this is the code, and I guess we'll see you all next week.
Okay, and then Dr. Maya,
claim my codes or whatever.
Yes, Dr. Unchak.
Yes, I have a question for you. It's a off topic. It's about I don't know if you want to just stay on after the others sign off, but it's
Sure,
a technical question about the PTS. Okay, very good.
Okay, thank you guys. Thank you very much.
Thank you. Bye-bye.
Okay, so Dr. Maya, you there?
Yes, Dr. Unchak. Yes, I'm here.
Yeah, no, I just want to ask you, I tried to access the Pan American Trauma Society website to look at the presentations. I tried to access my presentation from October 5th, 2000, because some of the staff here want to look at it, but it says that I don't have access to that.
Okay.
You don't have permission to access. Is there do I need a password or something, or how do I,
Okay.
how can I get access to that?
I'm not sure, but I
PTS
think Scarlett is the one who handles that. So I'll send her an email copying you, and then we can figure that out.
Okay, so the specific one that I'm interested in is October 5th, 2000. Okay. That one.
October 5th,
Great.
2000. Okay. Okay.
2000.
I'm going to send.
Thanks so much.
Yeah, I'm going to send out an email right now. Copying Scarlett.
Okay, and how was your exam? You look relieved. Your exam's behind you, right?
You see the relief.
You'll find. Yeah, well, you have to wait 4 weeks or whatever, but there you go. But it'd be nice to have it behind you, right?
Yes, it is. I'm actually leaving to India next week for my sister's wedding, so I'm happy that it's over.
Well, yeah, you'll enjoy it, and I'll be leaving in 6 weeks for India, so there you go.
Oh wow! Where are you going?
Well, the south this time. So Hyderabad, Bengaluru, Chennai, Cochin. Huh? Say what?
Perfect.
No, I was describing the geography of India. Are you going to Madras? Are you going to?
Yeah, the south. I was the north this time last year. Now we're going to the south, and I'm going to double back to Goa at the end, right in the middle there. So there you go. So I'm looking forward to it. Yes. Yes. Okay. Have a great trip in India.
Do you know around what time you're going to be in Cochin?
Not yet, but I have a full month, so you know, whatever. So Yeah, I
Have a
can
great
send you an email,
time.
whatever.
Yes,
Yeah,
I'll be
Rick,
in
thank you so
Cochin
much.
too. So for the entire month.
Yeah, and they tell me to go for the Paradise Biryani. So I got to see what's this Paradise Biryani. I got to.
Okay. So you compare the Paradise Biryani, and I will email you the real biryani place that you got to eat at. So you can compare and let me know.
Okay,
which
very
one.
good.
Okay.
In Kerala, very good. Okay, terrific. We'll do. Okay, thank you.
Okay.
Right,
Bye, Dr. Rodriguez. Thank you for
Bye
joining.
bye.
Bye bye. Bye bye.